The another thing, same thing. This group looks at where are we having trouble, and another spot is not trouble, but where do patients suffer the most. So thank you ATVs for showing us all the injuries that you can get, but people get crushed by ATVs, lots of rib fractures on both sides or in young people or what have you, but there's a lot of problems when you break ribs. You can get blood clots, you can get respiratory failure, you can get pneumonia as a secondary problem from that, you can get a popped lung. So we looked at having a really dialed method of providing basically good care and analgesia or pain control to these people. And we took a cohort of people before we instituted the multiple rib fracture protocol, plus our trauma nurse coordinator and the group just paying a lot of attention. So we just really focused on this as an initiative. So that was the cohort before, and then we added this protocol and just really intensive good care. So it means the anesthetists are even coming down and seeing the patient here in the emergency department, getting them ready for an epidural, which they place up in the PAR, the post-anesthetic recovery room. The nurses being well aware up on the wards that these patients need to be treated so well with pain control, otherwise they fail. The occupational therapists, the physiotherapists are visiting them, numerous times a day to basically badger them and get them breathing well, providing them with an incentive. It's called an incentive spirometer, which they have to suck on this little plastic gizmo to make the ball rise. What else? ICU care if required. So if they're looking that bad, they need to go to the step-down unit or the ICU to be watched really carefully. And so just doing that. So this is not rocket science. This is not, fancy surgery for those ribs. It's just really good care. And we showed that we knocked off an average of 3 days length of stay for these patients. And the best part was that there were, compared to about 40%, I think it was 40% of the patients went back to the ICU unexpectedly, and before we did that intervention, we had no unexpected admits to the ICU or step-down units. So basically, nobody failed medical treatment. So it's a lot of grief saved for the patient, a lot of complications avoided, and for the institution, a whole lot of money saved.